and it is 8:01, so we will go ahead and get started. I'm going to go ahead and quickly introduce you. I know we've had Dr. McCorkindale on, but I want to take a moment and introduce you. So first of all, let me just welcome you. We are so glad you're here for this ABHIN webinar this morning. This is a monthly webinar that we do, so please continue to join us. And if you have friends, colleagues, people who are working with you in healthcare, forward on this invitation. We would love them to join. All right, and with that, I'm going to give an introduction to our speaker this morning, which is Dr. Mandy McCorkindale. She is the Deputy Associate Chief of Staff for Mental Health Service and the Chief Psychologist at the Central Arkansas Veterans Healthcare System. She is formerly the Program Manager for the Primary Care Behavioral Health, known as PCBH, known nationally as Primary Care Mental Health Integration Program, where she worked from 2015 to 2021 and served as the facility lead for the VA's National Competency Training to promote fidelity to the PCMHI model of care. Dr. McCorkindale has served on numerous committees and in leadership roles within the VA and programs and initiatives to promote health and wellness. I'm great there. She has so many credentials that I'm skipping down just a little bit because we want to hear from her. Dr. McCorkindale received her doctorate from the School of Professional Psychology at the Forrest Institute, and her internship was with United States Air Force Wilford Hall Medical Center in San Antonio, Texas. Dr. McCorkindale is currently a major and the Chief Behavioral Health Officer for the Arkansas Army National Guard, and she is a member of the Arkansas Psychological Association, Collaborative Family Healthcare Association, and the American Psychological Association. Without further ado, I'm going to turn it over to Dr. McCorkindale. We really appreciate you giving you our time or your time this morning. Thank you.
Thank you, Kim. So let me just say, I'm at home today and my internet is telling me that it's unstable. So I have bipolar internet. If that becomes disruptive, I may shut my camera off because that seems to help sometimes, but we'll see how it rolls. But y'all feel free to stop me and say, you're frozen. Yeah, I'm going to talk as if you can hear everything I'm saying. So thank you again. And I'm really excited to be here today to talk with you all about functional assessment and using the 5A's model to do brief assessments. So I want to give credit where credit is due. Most of the material and the content that I put together today was actually created by the VA through their national competency training to train practitioners in delivering services from the primary care setting. So back in 2017, 2018, the VA rolled out an extensive competency-based training that is about 2.5 days in class, and then 6 months of follow-up training to ensure that that those who are being trained really get and utilize the model to ensure fidelity to this model of care. So functional assessment. What is a functional assessment? Or let me back up a second. So this is actually what we're going to talk about today. I'm going to talk about functional assessments, applying the 5A's model, the role and use of measurement-based care and brief screening tools. And then also I'm going to go through some tools and resources that are available to you all outside of the VA. So what is a functional assessment? This is, a different style of conducting a diagnostic interview. It has a very structured approach. it's problem focused and as well as risk assessment focused. Functional assessments, we use the biopsychosocial model. So probably you've all heard of that, but basically we're looking at 5 areas of functioning. We're looking at what might be going on physically with the patient. So that can be anything from their sleep, diabetes, hypertension, obesity. We're also looking at what's going on with them emotionally. So this is how they're feeling, depression, anxiety. And then the third area is cognitive. And so this is beliefs and thoughts and values, kind of how they're thinking about things. And then behaviorally, this is anything that a person does. So exercise, smoking, even medication taking, that would be considered a behavior. And then the 5th area of functioning is environmental. So that's, I think of that as like anything that is outside of the person that could be affecting the problem that they're presenting with. So work, school, family obligations, all of those sort of external factors. So functional assessments, we also really heavily rely on using screening tools for gathering information and also to assess whether or not the interventions and the treatment that we're providing is actually working. We use a shared decision-making model so that we're working collaboratively with the patient in creating a change plan. And you'll see that a little bit more as I go through the actual tool that we use. And then in our model of care, we always try to deploy evidence-based treatment so that we are using interventions that we know have been shown to be effective. I'm not going to go into a lot of detail today about actual evidence-based interventions, but that might be something in the future to consider. So this is just a really nice graphic that demonstrates the 5A's: assess, advise, agree, assist, and arrange. And so take note of how the arrows flow. We start with assessing. So we're looking at basically gathering information about what's going on, risk factors, symptoms, that sort of thing. And then as we flow into the advise phase, we're summarizing all of what the information that we've gathered. And then so that's sort of a transitional point. Advise is basically the sharing of options, or kind of, I think of it as like a menu of choices for what you can do together. Then the next is agree. So basically we're agreeing on what direction we're going to go, what course of action. This is sort of where the shared decision-making component really comes to play. And then assisting, this is the intervention. This is where we're creating a plan. And then arranging is basically kind of like what's next, what's going to be the follow-up, where do we go from here? And you can see that all phases of the interview are informing the personal action plan that you will create with the veteran or the patient. And then also as you are walking through each one of those phases, you are thinking about and preparing for how you're going to develop that personal action plan. Any questions about all of that so far? You'll have to unmute yourself.
Don't see anything in the chat yet, but I did invite everyone, and this is a good time for us to pause and invite everyone. We want this to be interactive, so please, if you have questions, type them in the chat, and Dr. McCorkindale will pause and answer them. So I'll let you know if what we get in the chat.
Sounds great. Okay, so this slide has a couple of resource tools that I'm going to walk through, and I actually already have them pulled up, so I'm not going to click on those. But this tool, you're able to see the functional assessment tool, right? Yes.
Yes, we are.
Alicia. Okay, so this is actually a tool that our providers use in the clinic when they are working with patients. This is kind of the longer version of it. There is a one-page abbreviated version too that I'll show you guys as we look at the next website. But I want to kind of walk through this because I think it's a really good guide to how to structure, how to actually accomplish a 30-minute session and pack in all the information that you've got to get and that you've got to give. So you start basically with an introduction, and I think that this is probably, to me, this is the most important part of using this type of assessment, as well as it'll carry over into future sessions and follow-up sessions. It's so important. I can't emphasize it enough, the importance of the introductory script. So I'm just going to spiel off my intro script, and you'll see how I hit all of those components within 1 to 2 minutes. So my name is Dr. McCorkindale, and I'm a behavioral health consultant. I'm a psychologist by training, but in this setting, we work a little bit differently. We work as consultants to the patients we work with, but also as consultants to the primary care providers. So here at the VA, we want to treat all areas of health, not just physical health. So your primary care provider has asked me to visit with you today. So I'm going to be spending about 30 minutes asking a bunch of questions, kind of getting an idea of what's going on for you right now. And then towards the end of our time together, we can figure out what's the best way forward, whether that's here with me in primary care or maybe another clinic within the VA. Also, since it's our first time to meet, confidentiality. So what we talk about is confidential, with the exception of anything that could be related to child abuse or elder abuse or abuse of a disabled person. Also, any risk of harm to yourself or to someone else that we can't create a safety plan around. Also, the records, the notes that I write go into our electronic medical record system. And so I will be able to coordinate with your primary care team, and they'll be able to see the notes from today's visit. And that's basically what I say on that first initial visit. I think that it's really helpful. You know, a lot of times patients who are seen in the primary care setting don't have, you know, they don't really know what to expect. This is their first time to ever see a mental health provider. And they think they're going to lay on a couch and spend a whole hour with you listening to them. But when you set the stage with the script, that really helps to kind of outline what the expectations are and set sort of some boundaries around what you're going to be doing today. So
Andy?
Then we move into summarizing the referral problem. So basically, this is where you're saying, your primary care doctor, let me know that you've been considering trying to reduce your alcohol use. You're recognizing that that is contributing to some high blood pressure. So that's why she asked me to see you today. But maybe tell me in your own words what's going on for you right now. And then I try to give them about 3 minutes, you know, not more than about 3 minutes of them, what is going on. Sometimes the answer is, yeah, that's why I'm here. But sometimes it may be a whole lot of other things. So it's important to clarify the problem before you start into the full assessment. So then you spend the next 12 to 15 minutes where you're really looking at, you know, staying very problem focused. In our traditional diagnostic interviews, we want an extensive history, and we want to know family background, and we want to know, all the things. But here with the functional assessment, we're really focused on what is the identified problem, what have you done, what has been done to try to help with the problem, what works, what makes it better, what makes it worse. And then you're looking at how is the problem potentially interfering with all these areas of functioning. So you're looking at sleep and work and family and, relationships. It's also really important to also assess, some of those health behaviors like alcohol use, tobacco use, any drugs, caffeine, because we know that a lot of those things can contribute and interfere with, what we might be focused on relative to the problem.
Hey, Mandy. This is Patty. I was just getting, this is really excellent. And one of the things, as I see who is on the call, a couple things I wanted to point out, that just in listening to your introductory script is a good description and shows how integrated behavioral health is very different than specialty mental health. And it's important for that to get established. It's important for the therapist who's doing integrated behavioral health to change the way they practice. And this is very different than our training. It's also different for we have other mental health clinicians on the line. We also have some people who are from the payer side and administration, and several other care coordinators who may not be mental health care coordinators. But this type of approach to assessing a patient could be used by any type of care coordination or anybody that needs to assess a patient quickly and get to a problem solving solution. And I know you're going to be getting into that, but I just wanted to help people see the context of why this is so important, and that this is really excellent in terms of practical. Somebody could leave today and at 10 o'clock apply this. So just wanted to thank you.
Yeah. Thanks for jumping in, Patty. That also kind of reminded me, we at the VA, we train a lot of interns and fellows. And, one of the things that I say when an intern comes in is, okay, you've been in school for the last 4 or 5 years, learning about the DSM and how to diagnose mental health conditions, you're all diagnosis focused. Now I'm going to tell you that you're throwing the DSM out the window, and we are going to be very problem focused. And that is really a hard transition and a challenging way to think about things. I mean, it is absolutely very important that in this setting, you have a very great foundation of understanding a variety of diagnoses and being able to kind of always have your ear open for something that might be, more in the severe mental illness. But even with a severely mentally ill population, this can be applied. Because this model of assessment can be applied, because it's very focused on problems and what might be going on right now, and then how to create a plan to help.
And it also speaks to why you can help a patient in one visit. A lot of times,
Absolutely.
Integrated behavioral health may only be 1 or 2 visits, or just very few. So this really shows how you can help them in one visit.
Okay, so here's the second page of the tool. And so at VA, when we had patients in the clinic, which I think they probably have more of that going on now, but we have the patient complete the PHQ-9, a depression screener, the GAD-7, which is an anxiety screener, the PCL, which is a screener for PTSD. And these are all just self-report measures. And then we have them do the audit C, which looks at their alcohol use. they complete those measures before they're seen by the provider. So you actually have those things in your hand, which is a extremely important tool to help you save time as you are walking through this assessment, because you can see at a glance, you've already asked them, probably, what is it, 9 questions. You've already asked them 50 or so questions by the way that they've responded on the screening tools. So you don't then have to verbally go back and ask all those questions again. You can focus on the areas where they indicated that they were having problems. So and then we have a risk assessment component where you're, definitely inquiring about any sort of suicidal or homicidal ideation, and that can then become the focus of the rest of the visit if that's, an issue that is going on. So towards the end of this assessment phase, I always ask, and this in my mind is sort of a transitional point for me, is there anything else that I haven't asked you about that you think would be important for me to know? So that's your catch-all. And then you're transitioning to the advise phase, but you're summarizing back everything that you've heard. And when I train, sometimes this comes really natural for people. They can automatically sort of think about, okay, here's where we're going with this. But when I train interns, I encourage them to use this summary component to kind of go back through the biopsychosocial model. And so you're saying these things out loud in a summary, which is rapport building, but you can also be sort of collecting your thoughts about how you are going to quickly approach what interventions you're going to use. So example would be something like, I would say something like, okay, so as I've been listening to you, I've really been thinking from this biopsychosocial model, which is this big fancy word that we use to kind of think about the 5 areas of functioning. And so I'm hearing that you're really struggling with managing your diabetes right now. And you've had some some problems with sleep. And you and your doctor are concerned about your hypertension. And that's part of why you were referred to me. I'm also looking at, what's going on with you emotionally. So, I know you said that your family member passed away and that's really created a lot of feelings of depression. I'm also looking at another area of function we call cognitively. So this is kind of how you're thinking about things. And I hear you saying that this is really a hard time for you, that you're not able to do the things that you want to do in life. I'm also looking at behaviorally. So these are things that we do. And when you told me that your medications have changed a lot and it's hard to keep up with when you're supposed to be taking them, that's a behavior. And then we're also looking at environmentally. So what's going on outside of you? And family, school, and work are all those kinds of things. And I hear that, troubles with family has definitely been a big part of, what's contributed to kind of where you are right now. And so sometimes we can't always control how we feel, and it can be hard to control how we think, but we can do things differently, hitting on the behavior part. So that's part of what I do, is to help people make change in the things that they do in their day-to-day life. So sort of, that's me off the cuff, kind of thinking up an example, but basically kind of summarizing everything that you've heard. And then as you put it into the biopsychosocial model, that can help you also transition to what are you going to do next? How are you going to present the advise phase of the assessment? And so I really think about this as the presenting kind of the menu of options. And I try to really keep it simple. So I hit on the behavior component when I'm doing the summary. I also think that behaviors are the things that we can most readily access for making change. And so a menu of options might be something like, so we can work together. As a behavioral health consultant, I can help you with creating some plans around how you can make some changes in your day-to-day life. We also have a pharmacist on our team, and I can refer you to her. She can also work with you to help with particularly your medications and, creating a plan for how to ensure that you're taking your medications regularly. And then another option is we have a care manager on our team, and this is a nurse who provides a lot of telephone contacts and telephone visits. And, she can be an additional provider that we can use, or she can work with you solely as someone who can sort of follow up and help ensure that whatever your goal is, she's, helping you to achieve that. So behavior change, medication options, care management. And then one that is often used in this setting is watchful waiting. So we can provide a little bit of education, and then we can not necessarily create a follow-up plan, but we can come back to, the patient can take the information that we're providing and they can apply it in their life. And then if they feel like they need to come back, they can schedule an appointment with us. Questions, thoughts, Patty, ideas?
We did have a question in the chat, and we've got a couple of questions actually. So the first question is there a behavioral health diagnosis needed to bill this service? And if it's not applicable at the VA, is that true in different types of primary care settings as well? So let me first ask you that. Is a behavioral health diagnosis needed to bill for this service?
So if a behavioral health diagnosis is present, we will use, a mental health diagnosis. If we are working with the patient solely on behavior change relative to a health condition like diabetes or hypertension, we use health and behavior codes. And at the VA, I know we're kind of different. So Patty may be able to fill in some gaps there outside of the VA.
Yeah, I think across the country, at least, psychiatric diagnoses are usually paid in an integrated behavioral health. That's a whole issue as to how to bill for those. The health and behavior codes have been inconsistently reimbursed across the country, and I'm not sure what our payers in Arkansas are doing, but generally they have been, it's when it requires a medical diagnosis first and not a psychiatric diagnosis, but that's definitely the more appropriate type of work that's done in integrated behavioral health. So it's a good question, and might be something that we want to follow up on, because that would be a great thing to be able to advance more integrated behavioral health, is to have that type of care reimbursed consistently and equally to mental health diagnoses. And the VA is different because you're not having to bill for specific services, but you're just having to track the work that you're doing. So you have a lot of more leeways, would you say?
Yes.
Yeah. And I'll speak to the time that I worked as a BHC was in an FQHC. And so at that point, we were using just behavioral health CPT codes because that's what was approved. The HNB codes at that point were not approved, but I think that's starting to change, and we're starting to see those codes turned on. The problem is the reimbursement for those codes. And what we see in traditional primary care settings that I've heard of across the country has been pretty minimal. So the next question was, what are the documentation standards for
Great
this
question.
type of visit?
So at VA, we've created a template that actually marries up with the functional assessment. So it has components of each of the functional assessment areas. So there's a problem, an intervention, and it's kind of an ongoing treatment plan. So in our specialty mental health programs, they are required to use a system called Mental Health Suite, which is a treatment planning software. But in PCMHI, we are not required to use that particular treatment planning. It's embedded within the template of our notes. And I'm not well versed in all things treatment planning outside of VA, so I'd have to defer to somebody else on that.
No, we appreciate that. Thank you. We do have a couple of other questions. Another question is there any literature on the use of this pediatric, on this model with pediatric or behavioral developmental issues?
Yes, there is. And it's been so long since I've had my head in the pediatric world that I don't know what the current state of the literature is, but I know my dissertation was on ADHD in the primary care setting. So it was really focused on kids. And when I was in the Air Force, I was able to work with children with this model, but that was 10 years ago. So
thank you. But it sounds like there's lots of stuff out there, so we could check that out.
Most definitely.
One more question was, someone asked, can they access this resource on the internet?
That's where I'm going next.
Great.
So let's finish up kind of walking through this functional assessment tool, and I will show you all the things that you will want to be able to delve into. Okay, so then you can see here, you spend the next 5 to 10 minutes or so with the assist phase of the plan. Again, this is the intervention. This is where you're shifting to what are you actually doing? Maybe that's providing education. Maybe that's creating a behavior change plan. You may be doing CBT for depression. You may, usually we are introducing some sort of tools, something on paper that they are going to walk out with. And the VA has created a lot of handouts, which I'm going to show you. And you guys will be able to access. And then the final phase is the next. What kind of follow-up are you going to have? When is that going to be? That sort of thing. And we always have them walk out with a behavioral prescription. So this is a piece of paper, kind of like a medication prescription of, what their plan is. And sometimes that may be, I'm writing down, you're going to exercise is the goal. So we're going to walk 3 times a week for at least 20 minutes each time, that kind of thing. So we'll have to do another session sometime on interventions, but let me show you the other tool. This link, and I'm sure that Kim can send this out to everybody. Actually, Patty, I'm sure you're familiar and remember and probably have used this even since you left the VA. VA does now have a internal facing only resource area, SharePoint. And so, but I was glad to see that they have left this Center for Integrated Healthcare external facing resource page that is still accessible. So basically you can Google Center for Integrated Healthcare, VA. You can probably pull that up. yourself right now if you want to. And when you pull it up, you're going to want to go to this tab over here for VISN2, Center for Integrated Healthcare, and then Clinical Resources tab here. So then you can see under this tab, oops, this is a lot of the tools. You'll see some policies and things, but also some of the tools that that VA has produced for this model of care. Practice management, here's the 5A's structure, the intro script, all the training tools, the functional assessment tools, follow-up assessment tools are there. I think this particular tab is really incredibly helpful because this has these are all handouts related to what we frequently see from primary care. These are handouts that can be provided to patients. So you can see like there's a ton of stuff here. I'm sure there are some non-VA sites that have produced similar material, but I just love how this is like so easily accessible in alphabetical order and designed specifically for primary care.
I just have to say, Mandy, I am so excited looking at that. That is absolutely fabulous. And one of the things that I just have to put a shout out, because I think as a BHC, when different specific problems are coming up and you're thinking about, okay, I need to give that handout, this is an amazing place to quickly go, not to have to spend a lot of time looking for a resource and have something alphabetically organized. This will be used all day, every day, I'm sure by lots of folks on the call. So thank you for sharing this.
Shout out to my friend Lisa Kearney, because she is the girl who put all this together. I mean, so organized, so structured. Yeah.
Beautiful.
Yeah, I used to carry around all these hard copy folders of all the, stress management worksheet, whatever, depression worksheet. And oh my gosh, I've used my last one. What am I going to do? No, it's all right here. So super easy. So patient education. And then there are also some handouts that are provider education. And one of the things that I would tell interns, I'm like, if you're seeing someone, if they're being referred for something that you have no idea what that thing is or what you would do with, how do you treat someone for, cirrhosis or whatever, like whatever, if you don't know, here's some tools right here, information about what they're coming in with, and then also information about what sort of intervention you can apply. And then this last tab is the measures. So we talked some about that.
And Mandy, go back to that last tab you had, because for others on the call, I mean, there's so much practical here for BHCs, but you've got that the VA's Foundation for Integrated Behavioral Health, those training manuals. It's like 6 of them. So if somebody is an administrator or trying to establish integrated behavioral health program, there are manuals there, there's policies, you can see there's functional statements for roles. And the thing about the VA is these are evidence-based tools and resources. They have collected them from various places, but they're evidence-based. So that's an important factor in integrated behavioral health, because since this is a new type of a role for therapists and for psychiatrists, psychologists, we often just go to primary care and start doing the thing that we were trained in, which is more specialty mental health. And it is a different skill set and it's a different knowledge set, because as you're sitting there seeing all this cancer, asthma, COPD, therapists, mental health clinicians of all types may not get a lot of training in that, but these are some fantastic resources. And they really do build from what you're talking about today, the foundation of the 5A's and the functional assessment. So this is excellent. Thanks, Mandy.
All right, any questions about these resources? Okay, I'm going to flip us back to the PowerPoint. Okay, so I want to take just a few minutes to talk a little bit more about measurement-based care and the importance of using measurement-based care in this setting and how we can use that. So, you know, we know what screeners we're talking about, and using those screeners when you're trying to compress so much into a 30-minute visit, then you can use those screeners as a way of saving time. You know, as I mentioned earlier, you have the patient complete them before the session, and then that can be an important foundation and sort of guidance as you move through the assessment. Also, measurement-based care using screeners helps us to really know is what we are doing working? Is the intervention working? Is the plan working? And it also can help to guide decision-making around when do we need to refer on to a higher level of care. So in VA, we try to keep our PCBH visits to not more than 4 to 6 sessions. If somebody needs more than 6 sessions, then we need to be considering looking at referring them on to specialty mental health. So basically utilizing the stepped care model. Also, I think that measures are particularly important because a lot of times people, you know, humans just, they don't know what depression is. They don't know what anxiety is. And they don't know how all those symptoms cluster together to create a particular, you know, problem or diagnosis. So sometimes just having the conversation about this is a depression screener and these are all symptoms of depression, and your score on this is 14, which is concerning, you know, mild to moderate level of depression or whatever might be going on. And so it can be used as a feedback tool also. And it also is, you know, useful for the PCP. You know, you're using it as a feedback tool for the patient, but as well as the PCP who has referred the patient over. So this last slide is just kind of some general tips on how to navigate a 30-minute session and keep it within that time frame. So very important. You've got to know why they're being referred. This is really important, you know, collaborating with your PCPs and helping them to know what you need to know to be an effective partner on their team is why they're sending the patient over, because that's your starting point. And then, of course, using the measures to guide you to save time. Basic rapport building skills are really necessary, a hugely necessary component to the 30-minute session. So if you're constantly looking at the computer, you're not making eye contact, that can be challenging for rapport building. Some people do it, have found a way to navigate doing the session and entering notes at the same time. Personally, I feel like I can't be effective at building rapport by doing that. So I actually use a clipboard, and I use the clipboard not only as a way for me to write things down, but it's kind of I learned way back in grad school with a forensic psychologist I worked with, talked about the use of the clipboard, commands control. So you have the clipboard, you're the one in control of the interview, you've got all these things that you're checking off, you know, this is me doing my job, asking you all these questions. But then when you start to hear something that you know that they need to get out, that they need to talk about, that they're going to give you more, you can set that clipboard aside, which sends sort of this nonverbal communication that, okay, now it's you know, we deal with a lot of trauma in the VA, and sometimes people are opening up trauma for the very first time, and you want to be able to allow them to do that. And you can then also use the clipboard as a way of saying, okay, now we're going to contain this trauma. I'm going to kind of take back over control of the session, because again, we're doing this in 30 minutes. So you've got to be able to navigate quickly between open-ended questions, closed-ended questions, staying within that time frame. So also, we're taught as clinicians to use a lot of open-ended questions, and that is, a beautiful way of building rapport and delivering quality services. And also in this setting, we need to use more closed-ended questions. So instead of saying something like, how is your sleep? You would say something like, are you having difficulty with sleep, difficulty falling asleep, staying asleep, or both? So yes, 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 or no, no, no. So you're sort of guiding them in that sleep assessment by asking those kinds of, sort of quick questions. Again, you've got a checklist that you're trying to accomplish. So, and then kind of the last point that I have here is ultimately you're really looking at how can you help them live the kind of life that they want to live? What are their values? What is important to them? And how does this problem interfere with in their day-to-day life? So, it's really, in some ways, the VA has whole health, and but primary care mental health is really kind of the foundation of this wellness approach, this getting people to live the kind of life they want to live approach. All right. We have 12 minutes.
Well, I'm sure we're going to have plenty of questions. We do have one question. Let me see if I can scroll to it. Sorry. Okay. Okay. The question is, what in the 5A's model, what A's would you consider an appropriate tool for possibly paraprofessionals or community health workers? Would you use, and we heard you all talk a little bit about this, but do you think this type of assessment model would be something that paraprofessionals or community health workers would benefit from using?
Yeah. Yeah. I mean, I definitely think that this structure of conducting an interview is applicable in so many different settings, as Patty pointed out, even medical, professionals, just, having this sort of problem focused structure. Yeah. We do actually, you'll see, let me pull the website back up. So VA uses nurses, primarily nurses, and sometimes social workers as care managers. And so I think it's this tab. If you see, care manager initial assessment training tool. So this is the tool that is used by that role on the PCMHI team, which is very similar to what I just walked through, but it's just slightly different. So in VA, the care managers are oftentimes they're nurses, and they work alongside either a psychiatrist or a mental health nurse practitioner or a clinical pharmacist. We use clinical pharmacists as prescribers in primary care. And so they are looking at kind of some different areas, but generally speaking, it's still embedded within the 5A structure.
What a fantastic tool.
Any other questions?
And the VA has used peer recovery specialists in the past. I'm not sure if that's a role that you're using now, and whether or not you have them on your integrated primary care mental health integration team.
We do. Amanda is still our peer. And yeah. Yeah, so I think we have like 13 peer support specialists in mental health service and also in patient services. So they definitely function. I think it's an incredibly important role, and they work within, they're embedded in several specialty areas, the substance abuse programming, residential programming, and then we have one in primary care as well. She's super helpful, particularly at managing, like helping with outreach, and also just being a veteran. Navigating the VA can be really challenging. So peers can help kind of walk through this big system that we have.
Mandy, I love the way you ended and said that that integrated behavioral health is a foundation of wellness and whole health, and that oftentimes in specialty mental health, we'll do this so long assessment, and that at the end, it's your diagnosis is this, and it's a DSM psychiatric diagnosis, and then we're going to do medication or CBT. And whereas this model is really, it's about the patient and where they are and helping them function and have a better life. And that's an area that mental health that we've struggled to make that connection. And so by having this 5A's model showing the integrated behavioral health, that's one huge value of having a person on the primary care team. But this whole format can be a common language for everyone on the team to use. And so whether they be a care manager or a community health worker or psychiatrist, psychologist, pharmacist, everybody will do it from their training, but be able to communicate, everyone knowing the areas that you're asking questions about and what's important to the patient. Somebody asked where the resource tool is, that 30-minute, that assessment you showed. She was curious as to where is that assessment on the website.
Yes.
I don't know if you can quickly get to that.
Oh. Let's see. So, yep. So it should be right here. So under practice management, functional assessment, initial appointment training tool. Let's make sure. Yep.
And that CCC, that stands in the VA for co-located collaborative care management care, which is a PCBH model, which is having a therapist or someone who is in the clinic co-located. Yeah, CCC, collaborative care. About 5 more minutes. Does anybody else have any other questions? Do you even want to come off mute to ask?
Okay, we've got someone that says, could we copy and paste the website link?
I put it in the link at
Dr.
8:36.
Gibson did, yeah.
The chat.
I think it's in the chat at 8:36. If you'll all scroll up just a little bit. It's on there.
There you
Thank you.
go.
Thank you. This is fantastic. These resources are amazing. Any last minute questions? We know it's 8:56. And if not, I just want to say, Dr. McCorkindale, thank you so much. This was very, very helpful. These resources are amazing. My guess is people are going to be blowing up the VA website, looking at all these amazing, amazing resources.
Hey, y'all put your tax dollars at work. So lots of money was spent to create all this. You guys should use it too.
We truly appreciate that. And like I said, I think as a BHC, especially when you're on the floor, sometimes you don't know what you're going to be seeing. And there's such a wide variety that if you could have these accessible, organized handouts that are alphabetical and oh my gosh, this is this place I can go. I could print this. I can give you a handout that is relevant to our intervention today. And I think it gives the patient then something tangible that they're taking and looking at. So I'm really excited. I also wanted to just say, I know we've got Megan on and with us. She is one of our Idaho colleagues. And I just wanted to say, there's an organization called CIHU that we've talked a little bit about, and they put on an IIBHN conference, which is the Idaho Integrated Behavioral Health Network. They are going to be doing that in April. So they'll be having a 2-day conference on integrated behavioral health. So if you're interested, please go ahead and check them out. And that is
Cool.
IIBHN. With that, any last comments? Go ahead, Dr. Gibson.
Next month, our speaker, do we have that set?
Yes, next month our speaker is going to be Dr. Amy Walters, and she is a health psychologist, and her focus is on diabetes. She works in a diabetes clinic as a behavioral health consultant doing interventions. So it's going to be fantastic. You're not going to want to miss it.
Thanks,
Megan,
everybody.
I don't know, Megan, if you wanted to give us the website or info for the conference.
Absolutely, Kim. I'm happy to do that. I was just pulling that actually up. The website is actually the best place to get the information about the schedule and tracks that are available. And so I'm pasting that in the chat. And let's make sure I get the HTTPS there correct. Let's make sure I got that correct. Okay, I'm pasting that there in the chat. Very low cost CME. And we feature wonderful folks like Patty and Kim at times. They were our presenters last year. And there are 6 tracks to choose from each day. So something for everyone on your primary care team, in your specialty behavioral health programs, and also OUD offerings. So thank you very much. And I enjoy your webinar so much. So thanks again, Kim, for always inviting us.
Oh, you are welcome, Megan. Thank you. We're so glad you're here. We appreciate everyone's time, and it is 9 o'clock. So we hope you have a wonderful day. And again, thank you, Dr. McCorkindale. And I know you brought up a couple of topics of interest. So we may be reaching back out to you to talk to you about, evidence-based interventions or different things. Thank you for your time today.
Sounds great. Thank you all.
Thanks,
Bye-bye.
Mandy.
Bye-bye.
Thank you.